Welcome back, colleagues, after this short break for the last but not least session of our meeting. And John, thank you for staying with us.
Pleasure.
I'm delighted to welcome and introduce Dr. Adrienne Kovacs, who is the next speaker. Adrienne is quite a colleague from a very special part of the world, from Portland, Oregon, and brings a lot of expertise and work, pioneering work on psychology and supporting our patients. She's the incoming president of the International Society of Adult Congenital Heart Disease and comes from a place that is very special to us. She's a senior colleague to Greg Broberg, who gave the opening talk of this symposium. And they're both in some ways a legacy of David's son that goes back some longer. And in fact, David's son and Christine are guest, honor guests to the meeting. And I hope they're listening to your talk, Adrienne, in the same way that we have Carla Wulm from the Wulm Foundation from Germany, who has also been a great support to Münster and to the ACHD cause. So, Adrienne, delighted that you could be with us. Sorry for getting you up early, but we look forward to your presentation. Thank you, Adrienne.
Thank you very much for that kind introduction. I'm 8 hours behind, so I've seen the past few presentations, and I'll watch the rest later. Greetings from Portland, Oregon. If you have been here before, it's a charming, friendly city, although I woke up this morning to learn that along with New York City and Seattle, we have been designated as an anarchist jurisdiction in the US. So we'll see what that means for us. Looking forward to speaking with you today. All right. So today I'll be talking about the patient perspective, what we know, and also how to learn more. So simple plan today. I'll begin by talking about what we currently know about patient-reported outcomes in adult congenital heart disease, and I'll focus on pulmonary hypertension from a research perspective. And then I'll move into talking about how we can learn about the unique experiences of our patients in the clinical setting. So let's talk about current research knowledge. We learn a lot from qualitative research. And so qualitative research refers to studies where we interview patients or we conduct focus groups. And a few years ago, we conducted focus groups of adults with congenital heart disease, and we asked them about what the main challenges were. And they distinguished between intrapersonal and interpersonal challenges. And some of the things they highlighted in terms of intrapersonal challenges were tolerating uncertainty, living with a chronic illness, body image concerns, seeking reassurance and hope. And I would say that clinically, the most common challenge I see is living with uncertainty. So not knowing when their health will decline, not knowing when arrhythmias may present, for example. And I think COVID has added an extra layer to uncertainty, not only for our patients, but for all of us. And we can also talk about interpersonal challenges. So they often struggle with feeling different, conflicting social expectations, when and how to talk about the illness with others, and also certainly social isolation. And again, we see that amplified in 2020. Some of you may be familiar with Approachies, and this stands for Assessment of Patterns of Patient-Reported Outcomes in Adults with Congenital Heart Disease, an international study. And between 2013 and 2015, we recruited over 4,000 participants from 24 centers in 15 countries around the world. And they completed a lengthy battery of questionnaires looking for patient-reported outcomes. And so what we mean by that is asking patients how they are doing in their own words without any interference or bias from health professionals. And our first outcomes paper, the original main paper, was published in 2016. And I'd like you to humor the psychologist for a moment here and just think about how you would rate your quality of life on a 0 to 100 scale, ranging from 0, worst imaginable, to 100, best imaginable. And we ask patients to do this. And if we were in person, I might ask for a show of hands. I won't do that here. But just think about how you might rate your own quality of life. This is what we found from patients. So the median quality of life rating was 80. And the interquartile range was between 70 and 90. And you can see that there are some differences between countries. So highest median rating was Australia, lowest here was Japan, and the darker shading refers to more common responses here. I think that many of us were actually pleasantly surprised at the median high ratings that we observed here. And I will say that when I have polled audiences, when I previously asked about this, oftentimes the median rating is below 80. So I don't know what that says about our profession. And in multivariable analysis, these were the 4 factors that significantly predicted poorer quality of life: older age, lack of employment, no marriage history, and worse NYHA class. And although disease complexity, mild, moderate, or severe, was a univariate predictor, it did not emerge in the multivariable analysis. And we've since published, over a dozen studies, and this is the one most recently that came out in the Canadian Journal of Cardiology. And what we did is we looked at, this sample here included just over 3,500 patients, and we looked specifically at differences between diagnostic categories. And we included patients who fell into diagnostic categories that had at least 50 patients per diagnosis. And on this linear analog scale, so that 0 to 100 scale, again, the median for the entire group was 80. We can see that there was a significant difference here between some of the diagnostic categories. And right at the top there, we can see cyanotic heart disease, or Eisenmenger syndrome. We had 72 patients who fell into that category, and their mean score was 67, and that had a moderate effect size falling into that diagnostic category in terms of understanding quality of life. And I think this is particularly relevant for the current session we're in. We also administered the SF-12, which is a measure of health status. And once again, we can see that the group that had the poorest scores, so a mean of 53, and compared to coarctation of the aorta, had the highest mean score of 83. And these scores range from 0 to 100. Once again, we see that cyanotic heart disease and Eisenmenger syndrome had poorest physical health status. We also looked at scores on the hospital anxiety and depression scale. And this is a 14-item measure, 7 items looking at depression, 7 looking at anxiety. And on each subscale, a score of 8 or higher suggests clinically elevated symptoms of depression or anxiety. And again, here we can see that of the both categories of symptoms of psychological distress, the cyanotic and Eisenmenger patients had the highest scores, or the greatest number of symptoms. And just a little observation here, we see that anxiety scores tended to be higher than depression scores. And I think that's really important to be mindful of. We historically in behavioral cardiology, we focused on depression as a primary outcome in people living with heart conditions. And clinically and in research, we often see that anxiety symptoms are more prominent. And so I think it will be interesting to learn what the story of Approach IS2 will be. So we launched in 2019, part 2 to this. We have, I think, about 80 centers currently agreeing to participate. A few centers began data collection before the pandemic, and many are collecting data right now. And we don't know what the impact will be. I think that when I asked you to think about what your quality of life might be on a 0 to 100 rating scale, you might give yourself a different rating than you would have 7 months ago. And I know that I would have. And one of the advantages of having the the data collected a few years ago, is we'll be able to look and see if there are any changes in some of these main outcome scores following following 2020 and COVID. So a couple other studies to share with you. This one comes from France, and they administered 3 specific patient-reported outcome measures to 208 adults with congenital heart disease with pulmonary hypertension, followed at one of 14 centers. And they administered the SF-36, which is a measure of health status. It produces 2 component summary scales, physical health status and mental health status. They administered the Cambridge Pulmonary Hypertension Outcome Review, as well as the Hospital Anxiety and Depression Scale. And here we can see these are scores on the SF-36 here, the physical, the entire measure. The black bars on the left refer to the physical component and the mental component summaries, and the purple bars to the right focus on specific subscales. So we can see that across all of these scores were lower than the average American population, which shows poorer health status compared to normative data. And then here they looked at, on the left, the figures for the CAMP4 scores. On the right, it's the Hospital Anxiety Depression Scale. And here they divided things by New York Heart Association class. And on the left, we can see that the 3 subscales of symptoms, functioning, and quality of life tended to worsen. So higher scores indicate poorer functioning or greater impairment. Those with higher NYHA class tended to do more poorly. When we look at hospital anxiety and depression scores on the right for anxiety and depression, there was less of a clear impact of NYHA. So we see that people with no functional impairment tended to do better. And I will say that when we look at psychological outcomes, even in clinic, I think when I began as a psychologist in Toronto over 15 years ago, oftentimes providers thought that they ought to be most concerned about patients who had more significant psychological distress, significant congenital heart disease. And I think in my own clinical practice, I am referred patients who have mild, moderate, complex disease. And so I see less of a relationship in terms of that. Finally, a study from the Netherlands, they administered the SF-36, again, that measure of health status, to congenital heart disease patients who also had pulmonary hypertension. And they looked at them across who were treated for 2 years. And of the 39 patients enrolled in this study, the physical component summary, so physical health status, decreased in 13 patients and did not decrease in 26 patients. And if we look at the figure here on the right, the darker line on the top refers to the patients whose quality of life did not decline. The broken up bar below refers to those patients who had declined quality of life. And we can see that there's a significant change in survival, the survival outcomes. And in fact, the 5-year survival was 29% in the group with decreased physical health status, compared to 74% in the group that did not have any decrease. And certainly the authors discussed whether physical health status reported by patients may be a proxy for disease status. It was interesting that it was the decline or the change that was significant rather than baseline health status. And this also highlights that it may be helpful to be mindful of administering surveys like this and asking about quality of life and self-reported health status to understand what the trajectory might look like and whether we want to use that to factor that into our decision-making of when to intervene. And we talk a lot about, I'm a clinician and a scientist, and we often rely on our own published data. And I'm reminded that sometimes patient and illness organizations do a really great job of providing helpful and informative data. So this is from the Pulmonary Hypertension Association of the UK. And they actually had over 500 respondents complete a survey in 2016. And they found that 60% reported that pulmonary hypertension has a major impact on their overall quality of life. 32% reported that it had a major impact on general mental and emotional well-being, and over an additional 50% reported that it had somewhat of an impact. And 26% reported that pulmonary hypertension has a major impact on relationships and family. And again, another 50+% reported that it had somewhat of an impact. And the good news is that almost half of them reported that treatment and management improved their overall quality of life. So if we take the data, I think the next step is to figure out, well, how do we apply this and how do we learn about the unique experiences of our own patients in the clinical setting? So I woke early this morning to listen to Gerhard Diller's excellent presentation on machine learning. And I think right now we're talking about how do we kind of take this down here to the individual patient level. And to paraphrase Dr. Claudia Montanaro from her presentation yesterday, we have to think about what is best for the patient and not just base our decision on the echo. So this really is getting at making individualized decisions. And we do not have a crystal ball. And it's also very important to avoid assumptions. I think that often it's easy to fall into the trap of thinking, what would we feel if we were in the patient's shoes? What would be important to us? What decisions would we maybe make? And I think it's important to actually obtain that information directly from patients. So here are some things we might ask. How are things going for you lately? We can ask them, how would you rate your quality of life on a 0 to 100 scale? We know that the average is around 80, between 70 and 90. So to me, I kind of think if it's below 70 in the average ACHD population, I might be concerned about that. Although we do know it is lower for those with Eisenmenger physiology. Does thinking about your health make you feel worried, afraid, or depressed? How do you cope with stress? So these are just general opening statements, opening questions to gather more information about the patient perspective. What questions or concerns do you have about your health? How is your health different now compared to 5 years ago? And I think that's an important question because we often, patients will experience very subtle, gradual defects over time. And so things may not seem different than 6 or 12 months ago, but comparing it to 5 years ago, I think can be particularly informative. What challenges do you face managing your health? And I think this is where we get into that issue of adherence. And I think that, you know, many of our patients, we hope that they would attend clinic visits every time. We hope that they would exercise and be at a healthy weight and avoid significant alcohol and take their medications as recommended. So rather than come in with a firm accusatory tone, being open and saying, we know it can be really difficult to do this. What are the specific challenges that you face? And finally, what are the most important things I should know about you when we make healthcare decisions together? So when we ask this question, we get different answers. And some people may talk about fulfilling jobs or children or nieces and nephews or hoping that they can go fishing for as many more years as possible. But this is important information that helps us ensure that we are not making decisions based on assumptions. And here I've provided a list of statements to normalize and destigmatize emotional difficulties. Many of our patients will struggle with low mood or anxiety at some point in their lives, so let them know that this is understandable. We understand that living with a heart condition can affect more than a person's heart. It can affect a person and their family in many ways. It is understandable that your health history would have an emotional impact. I say this to people every time I meet a new patient for the first time and they share their history with me. I always, almost always make this statement. Even patients who are strong, independent, and resilient sometimes struggle with their emotions. So psychological distress and emotion and resilience are not mutually exclusive. And please let me know ever if you're struggling with low mood or anxiety now or in the future, because these things can change over time. And here are some general strategies here. And we published these in a paper looking at psychological outcomes in congenital heart disease. I think that the first 5 on the list probably apply to just about everybody in the world right now, including patients with or without congenital heart disease and even providers. And I share this list with you because I think that although I'm a psychologist, you don't have to be a mental health professional to make a difference. So encourage medically appropriate physical activity, which may have mental health benefits in addition to physiological benefits. So the nice thing is to get the psychological benefits. Doesn't matter how long we exercise, how intense it is, what we do, it just seems to have a positive effect. Encourage activity pacing, so not overdoing it on good days. Ensuring that patients are not avoiding preferred activities out of fear. So ask them if they're avoiding certain things, and they may do so based on medical recommendations, but we want to make sure that they are not unnecessarily limiting themselves. Encourage planned participation in pleasant activities. So make sure that they are planning for and engaging in really fun, rewarding things in their life. Offer positive verbal reinforcement for the practice of healthy coping strategies and outcomes. So if you and a patient discuss that the goal is to lose 20 pounds in the next year, and they come back and they've lost 5 pounds, congratulate them on the 5 pounds they've lost. Provide information about opportunities to connect with other patients, and also offer events for them to interact with one another and to share coping strategies. Oftentimes they'll tell you that some of the most powerful experiences they have is when they interact with one another. So in conclusion then, among adults with congenital heart disease, we know that those with pulmonary hypertension tend to report the worst scores on patient-reported outcome measures, and that applying this information to the clinical setting does require understanding the unique circumstances of individual patients. And thank you.
Michael, you're muted.
Huge. What a wonderful talk, Adrienne.
Thank you.
And the last 2 slides, absolutely spot on. And as you said, not just for the patients, but for us too. And so relevant going through this, challenge with the clever virus.
Yeah.
Absolutely wonderful talk.
Thank you
so much.
It was fantastic. Oh, we've lost Adrienne.
Yeah,
I thought I was supposed to go. I'm sorry.
Yeah, no problem, Adrienne. Adrienne, may I ask you a question? Because, I dream a lot. Maybe that's a good thing, maybe a bad thing too.
We think that's okay.
Yeah, okay. Well, I'm honest about it. But, we had a wonderful session, rapid fire session. And it was a bit jammed. We didn't have much time to discuss. And the last presenter was Jane Wood, who did a fantastic job. She's a palliative care physician working with us and the Marsden. Were you part of that session? Did you follow or not?
No, that was too early for me. I joined right after that.
Yeah. So, what I was saying is, out of my humble experience advising pregnant women, not pregnant women, women who are contemplating pregnancy with congenital heart disease, and you have to, confront yourself and tell the patients about lifespan, not in specifics, but more or less. My experience of this is that it's not a problem. That patients receive that, with the exception of one patient who was very upset and had trouble with Phil's chair, receive it well. And with a positive reinforcement around it, that some patients may not have a normal lifespan, but they can plan their lives, they can have their children in good time, they can do all the things that can help themselves. Do you have any comments on this? Is there any data to support it?
Yeah. It's interesting. I know Daniel Tobler was on the agenda earlier this morning. In Toronto, we actually did research with Daniel Tobler and Matthias Grootman. And we did a similar study in Philadelphia. And we surveyed patients. We asked them whether they wanted to discuss advanced care planning with their providers. And about 75% said yes, it's important to them. Very few had had these conversations. What's interesting also is in the Philadelphia sample, we administered the hospital anxiety and depression scale, and we found that patients who had higher anxiety were actually more likely to want to have these advanced care planning discussions. And in samples, we said, do you like information about the average life expectancy of people with your diagnosis? And about 2/3 said yes. They did not want to necessarily know when they themselves would die, which is kind of good because that's
Nobody does.
and impossible to provide, but they actually wanted general information about their life expectancy. And I think, you raise an important topic because I think that as providers, we have historically shied away from those discussions because they make us uncomfortable. Patients often want to have these discussions. And what I tend to do is I invite them, and I use the term long-term health expectations. So I would say, let me know if you ever have questions about your long-term health expectations and discussing those with your cardiologist. And I'll say this, I have never had a discussion regarding future health expectations or advanced care planning that the patients are not happy that they had.
Yeah, thank you so much, Adrienne.
Sure.
I really appreciate this.
Thank you.
Lovely talk. There's a question that's come through from Pak Chow, who compliments you on your talk, and says, what do you think of the role of illness perception? Recently, he has submitted a study on quality of life in ACHD patients and found that several domains of illness perception related to poor quality of life. From your experience, is there any way to improve illness perception in these group of patients?
Yeah, I think, so by the way, I'm going to have to say yes, because I'm a psychologist. So I'm going to say my goal is to do that. And I think, when we talk about illness perceptions, we talk about things like how they perceive the illness affecting their identity and the level of control and understanding and the way that it affects them. And I think these are things that we can intervene. And so I think, I'm a cognitive behavioral psychologist. So helping people learn how to think about an illness in different ways, in more effective or adaptive ways. I think anything that we can do that empowers patients. So I think education is an important component there. And sometimes in my experience, people perceive limitations or concerns or they have assumptions that aren't always accurate. And that's why I always encourage providers to say, what questions or concerns do you have? Not to say, do you have any questions? It's just to say, what are your concerns? And so that way we know that we're not expecting a yes or no answer, and we assume that they will have questions and concerns. So tell me what they are. And that way we can address any misperceptions that people might have. And again, to me, the goal of quality of life is to help people live as rich and full a life for as long as possible. So sometimes it's directing attention toward that. And, again, we're doing the same thing, all of us right now in 2020. So, we again are living with health uncertainty, and this certainly is not how we anticipated living this year. I thought I'd be getting ready for a swinging 60s party right about now. And so I think we are adjusting the best we can. And certainly we see that how we think about a situation, how we adapt to it, can affect our well-being and our quality of life. The one thing I'll add, and I tell patients this, and I tell myself this, is mental health, psychological well-being, it takes effort. So just like our physical health takes effort, it requires meal planning and exercise and these kind of taking our medications. Improving our psychological well-being, our emotional health also takes a bit of effort.
Thank you.
Great question.
There's just an interesting follow-up question from Grushin.
Hi, Grushin.
Who obviously says what a wonderful talk. Thank you for the practical advice. You showed how our patients rate their quality of life. I would be most interested in what providers' quality of life responses would be. What do you think their responses would be?
Yeah. So sometimes I do this and we have a show of hands, and I will say, there are some people who will say, oh, it's 100, it's great all the time. And I find that hard to believe actually that anybody would be there, but maybe on a good day. I would say that it ranges, but when I have surveyed groups before, the average has never been 80. So it tends to be in the 70s. And I think there is something about adaptation and our expectations. And so I think that people, they look at where they are now, where they were, what's important to them, different values. But I think that's why I like to share this with providers and ask people to think about what their own quality of life rating may be, because it's been a bit lower. And I will say for myself, I'd probably say before COVID, it was maybe between 70 and 90. And I'd say that, we've also had here in Portland horrible forest fires. So we have been, we've essentially been stuck inside for the previous 2 weeks. All of these are challenges that significantly, I would say, have dropped our collective quality of life double digits. And I will add that, the reason that we focus on that quality of life, and I should have mentioned that I'm on the oversight committee for this, but Philip Moons in Leuven, Belgium is the guru of this project. And I would say he's the guru of quality of life in adult congenital heart disease. And he introduced our field to this measure, this 0 to 100 linear analog scale. And the reason we use that is it allows us to look at quality of life, both related and unrelated to health. So we are not assigning a certain domain. We're not saying we want to know about health-related quality of life or ACHD-related or relationship-related quality of life. We allow the respondent to think about what impacts their quality of life at the individual level. And I think this year we've all faced really interesting challenges that have challenged us to come up with new coping strategies.
Thank you.
And yet we're still here.
We're here.
And so optimistic about the future and opportunities.
Yes.
Patients and for